So there's lymphocytic infiltrate. It's mostly lymphocytic infiltrate, but it's too far to see what type of cells here. But I want you to tell me the pattern mostly. Do you guys all see the screen now? Okay. So what's the pattern here? I can see perivascular, superficial and deep perivascular, and perifollicular, and there's an interface dermatitis. What condition comes to mind when you see a superficial and deep perivascular infiltrate, follicular plugging, um, interface dermatitis? So lupus is the classic condition that would give this. So if we go back to our first image of this lecture, you can see here um, this hypertrophic plaque um, in the dorsal foot. So, given the clinical pathological correlation now, what would your preferred diagnosis would be? Exactly, discoid lupus erythematosus. So you gave me a good differential diagnosis. Some of you said hypertrophic lichen planus. Some of you said necrolytic acular erythema, allergic contact dermatitis, which would probably be the chronic type. You mentioned um, um, uh, psoriasis, but initially no one mentioned discoid lupus, but the pathology was so classic that it helped us find the correct diagnosis. So moving on to the next case, can anyone tell me what this is, or what's the differential diagnosis for this? Sweet syndrome is a good differential diagnosis. Milker's nodule and or perfect differential diagnosis. Pyoderma gangrenosum, that is also a nice differential diagnosis. Perfect. So you tell me a lot of nice differential diagnosis. So I like ORF and Milker's nodule, which usually look very much the same. I like pyoderma gangrenosum, and I like sweet syndrome. Um, and leishmaniasis, very nice, very good. Leishmaniasis is a good differential diagnosis as well. I would also add anthrax into the differential diagnosis there. Ulcerated hemangioma, okay, but it would be less than the rest, but also a nice differential diagnosis. If this was sweet syndrome, and I told you that this was only localized on the upper extremities, and there was not much of a fever or constitutional symptoms. What subset of sweet syndrome would you think this is, if it was sweet syndrome? There's a type of sweet syndrome or a variant of sweet syndrome which is much less severe. Neutrophilic dermatosis of the dorsal hands. Perfect, exactly. So neutrophilic dermatosis of the dorsal hands, that would be the form of your differential diagnosis. Good. So now with the pathology for this patient, what do you see here? First, before we talk about the cell that is involved, is this diffuse infiltrate? Is it a perivascular infiltrate? Is it an interface? Is it psoriasiform? How extensive is the infiltrate here? Diffuse. Okay, so we say a diffuse infiltrate, and when we look down and see the players, what cell? I taught you the cell types last time. So what type of cell do you see here that is very prevalent? Neutrophils. Good. So you see a diffuse neutrophilic rash here. If you go back to this image, now what would your differential be? Diffuse infiltrate with edema in the upper dermis. So sweet syndrome is my preferred diagnosis for this one. You cannot entirely rule out pyoderma gangrenosum because it looks histologically similar, but the clinical image is more classic for sweet syndrome for this patient if it was more acute and if it was involving multiple fingers at the same time. If this patient had this ulcer and then started to expand and it was only one or two ulcers, you would think more of pyoderma gangrenosum. But in this case, this is sweet, and in particular, the variant that is neutrophilic dermatosis of the dorsal hand. Okay, moving on to the next case. LSNA is a good differential diagnosis. What else? Come on, other people as well. We need to hear you all give your differential. LP, okay, very good. Anything else? So elaborating more the answers. So the same we're getting lichen planus and lichen sclerosis. What if I told you this patient has had this for 8 months, for example, and it's expanding rather than coming and going away? Contact derm is also a good differential diagnosis, but it would be more if I gave you the scenario of acute. But if it's chronic, I agree with Paget's. That's a very good differential. Paget's disease, extramammary Paget's disease. That's a good differential diagnosis because chronic. Um, I like your differential, but for saving time, I would also add to you two more differential. Always don't forget to mention neoplasia if it's not improving with any treatment. It's not what this is, but you have to keep it in mind. Also think of mucous membrane pemphigoid as well. It can also give this kind of presentation. So let's go to see the histology. Let's see the histology. What kind of infiltrate do you see here? Here mainly. This is more of a lymphocytic band-like infiltrate. Okay, good. Lymphocytic band-like infiltrate. There's what this looks like it is going up to the epidermis, but it's more about the awkward cut, and this is more of a vacuolar interface dermatitis that is just it looks higher than it actually is, but it's not. So you got some apoptotic cells, which we call them colloid and civat bodied, perfect, and you got your band-like infiltrate. So what would your differential diagnosis or actual diagnosis be here? Come on. So lichen planus, good. So this is more closer towards lichen planus. If you go back to the image, I'll tell you a hint. I mean, to me, when I see this image, I would think first of two main entities. I would think of lichen planus and lichen sclerosis. Um, when I would biopsy this lesion, I would take two biopsies. I would send one for immunofluorescence and one for HNE. The one for immunofluorescence because it would help rule out mucous membrane pemphigoid if that was the case, and it is somewhat a little bit helpful for lichen planus if we can see fibrin in the dermal junction. But I'll give you one hint that would really help you even clinically say that this is much more likely to be lichen planus than lichen sclerosis. You see here the involvement of the vagina from the inside. Lichen sclerosis doesn't usually do that. Lichen sclerosis would involve the labia majora and somewhat in the labia minora, but it does not all involve, you almost never see it involve all the way inside the mucus, the vaginal mucosa to the extent that lichen planus does. And lichen planus also, if it's very severe, it would cause a desquamative vaginitis, which usually you don't see in lichen sclerosis. So this is a case of genital lichen planus, the erosive type. How would you manage this? Just very quickly. How would you manage this condition? Methotrexate? Not really. There's some more effective treatments and more localized treatments. Super potent topical steroids and skincare. That would be the how I would manage it. You minimize any irritants to the area. Let's say you're using of soap and using any moisturizer that would soothe the area. But at the same time, super potent topical steroids would be the mainstay of treatment. And in most cases, this would be the agent that would help the patient. And given that this is lichen planus rather than lichen sclerosis, if super potent topical steroids didn't work, and usually it does, you can move on to systemic steroids for treating this condition. And treating lichen planus is done for the same reason as that for lichen sclerosus, is to prevent scarring in the area, and more importantly, to prevent squamous cell carcinoma to develop in the area. Let's move on to our next case. Can anyone tell me what this is? Or at least what the differential diagnosis is? Scabies is a good differential diagnosis. Cephalic pustulosis, I like that diagnosis, but why is it involving the hand as well? Both of them are the same condition. So if it was only the face, and cephalic pustulosis usually involves the face, which is also called neonatal acne. So I wouldn't agree with that. I agree with acropustulosis of infancy. I agree with Langerhans cell histiocytosis. I agree with scabies because scabies can involve the head and neck in infants and babies. So I like those three differential diagnoses. Bullous syphilis, to an extent, it usually involves the genital area most, but I will not rule it out. It's also a possibility. There are more important differential diagnosis here, but let's look at the slide to help you with your differential. Histiocytosis, that is correct, and particularly when you said Langerhans cell histiocytosis. So let's look here. What do you see here on the hair follicle? Even at this power, you can see a type of cell that is very, very obvious from this power. What cell am I pointing at? I don't know if you see my arrow or not, but there's a cell that is prevalent. So eosinophil, perfect. So there's eosinophils around the hair follicle, which we call eosinophilic folliculitis. And then you see this again. Oops. Okay, going back. So what would you say? Erythema toxic immunitorum, usually it occurs in infants that are only a few days after birth. It doesn't give these pustules and crusted pustules, and they're not particularly perifollicular. They're near the follicles in terms of infiltrate histology, but they're not within the hair follicle. They don't cause any eosinophilic folliculitis. Bedbugs would be a good differential diagnosis before they seeing the histology. Have you guys ever heard of eosinophilic pustular folliculitis? So eosinophilic pustular folliculitis, there's three types. There's the eosinophilic folliculitis of HIV, which is the commonest one I've seen. There's the very rare type that mostly occurs in Japanese, which is eosinophilic pustular folliculitis of Fuji. And there's the third type, which is eosinophilic pustular folliculitis of infancy. So of these three types, which one would this be? Of Fuji or HIV or of infancy? Of infancy, perfect. So eosinophilic folliculitis or pustular folliculitis of infancy mostly involves the scalp, but it has been seen to involve other acral areas, which is the reason I showed you this, because I wanted you to be aware that it involves other areas as well. Um, so how would you approach and treat this condition? How would you treat this condition? You can give first of all, you give reassurance to the patient that it will improve. But if the patients or the family basically are seeking active treatment, you would give topical steroids. Yes. So topical steroids would be the mainstay of treatment. If not, you can just tell the patient's family that this condition does resolve on its own. Okay, moving on next to the next condition. Okay, this is more for the, let's say, senior dermatologist here in the group. It's a little bit of a complicated condition. I can see eroded, ulcerated, crusted lesions on the knee of the patient. Hypertrophic LP does not usually lead to these erosions. Hypertrophic LP is more of hyperkeratotic, acanthotic, and thick. This is more crusted and ulcerated lesions on the elbow. HSV is a good differential diagnosis. I like that. They are like, grouped. What if I told you this patient had vasculitis elsewhere in the body? If I told you that this patient had vasculitis elsewhere in the body, I like atrophy blanche. I like that, but it's a little bit high. It's in the knee rather than in the calf. Nodular vasculitis, I wouldn't agree much with it because it's not really nodular. It's like crusted papules. I like EED as a differential diagnosis. Very good. When a Dagos, I really like Dagos for this one. Perfect differential diagnosis. EED is nice. Dagos is nice. Palisated neutrophilic and granulomatous dermatitis. I really like this differential diagnosis, and you're really picking up on the mention of vasculitis elsewhere. So I like your differential so far. Really good differential diagnosis. So let's go and see the image. So I can see here, just to guide you through the histology, I see an area of necrotic collagen. If you can see here, a lot of necrosis, and it's more of a basophilic necrosis rather than eosinophilic flame-frequent necrosis. And I see a lot of macrophages. When you see a lot of infiltrate and you see like a grayish hue, even from low power, when you see it's like more pinkish, you think of eosinophils. If you see it's like very blue, you think of lymphocytes. When you see it's like grayish, very slight pinkish, you think of histiocytes. So there's a lot of granuloma, let's say palisading granuloma here. This is more of a palisading granuloma. And I see a little bit of vasculitis here, leukocytoclastic vasculitis. So if you see palisading, neutrophilic, and granulomatous dermatitis, what do you call this? Palisading, neutrophilic, and granulomatous dermatitis. So good job on for Hanan Al Salman for mentioning that diagnosis. Which disorders usually give you this finding? We know that PNGD is not a diagnosis by itself. It's a histological and somewhat clinical pattern seen in several conditions. Can anyone tell me the conditions that can give us this pattern very quickly before we move on to the next condition? Rheumatoid arthritis, very good. What else? There are one or two entities that are more closer towards dermatology. Interstitial granulomatous drug reaction, that is very good. But what the answers I was looking for is Churg-Strauss syndrome, which is the eosinophilic granulomatosis with polyangiitis, and Wegener's, which is granulomatosis with polyangiitis. These two entities are very important for your boards to know that they can cause PNGD. Okay, next. Give me the differential diagnosis for this one. I'm focusing on this entity here. The patient has these papules, but then I noticed a blister here in the towards the base of the thumb. Bullous LP. I like that differential diagnosis. Very good. What else? Remember always with these with LP pemphigoides. Very good. So history is important here. IgA pemphigus. Okay, you're noticing the annular pattern, but remember, IgA pemphigus mostly involves the flexures of the body, but still, it can be. It all depends on what we see histologically. So far we got three differential: bullous LP, LP pemphigoides, IgA pemphigus. Anyone wants to add anything? Before we move on to the histology, there's at least one thing you guys need to say and need to be aware of. You're talking about acral lesions. Some of them are starting to blister. You have to think of this entity. Let's say the patient also has genital involvement, and other family members have it. Porphyria, okay, I don't mind porphyria as a differential diagnosis. This could well be porphyria. I agree. Scabies, exactly. Good job, MK. Which I think is, I assume, is Malleum and Nodgem. Um, I like this differential diagnosis. Scabies, you have to keep it in mind. So let's go to the histology. What do you see histology? Okay, so I know it's low power. You can't tell exactly what the cell type is, but but when you see it's like diffusely blue, would you think of when you see it from low power, really blue, and they're all like rounded? You see this, so these are lymphocytes. Perfect. So you see a lot of lymphocytes, a cleft between the epidermis and dermis because of the heavy lymphocytic infiltrate. What would this be now after seeing the histology? Porphyria cutanea no, because you don't see the festooning. Porphyria cutanea does not have much of an inflammatory infiltrate. So yes, so bullous LP. So depending on the history, bullous LP versus LP pemphigoides, you depend on two things. You depend on if you took a DIF, if the DIF is positive for C3 linear C3, and if you see lesions that develop as blisters without the lichenoid papules. So in bullous LP, the blisters will only develop in the areas of lichen planus because like you see here in the image, the infiltrate is so heavy and strong that the dermoepidermal junction will be damaged and split. In LP pemphigoides, it's basically the patient has two conditions, has lichen planus and bullous pemphigoid. And if you blister and if you biopsy this area, you would see not features that look like lichen planus that we see here. You would see features that look more like bullous pemphigoid, which you would see using a lot of eosinophils and also festooning, by the way. So when you see festooning under the blister, you think of two conditions: porphyria cutanea and lichen planus. Moving on to the next slide. So we're done with the clinical pathological correlation. We're going to go for some spot diagnosis cases. I want you to answer a bit faster so we can go through more slides before our time's up. So this patient has these lesions with exercise mainly, itchy evanescent papules that develop when the patient is exercising. Cholinergic urticaria, perfect. How would you treat it? Very quickly, stepwise. Someone tell me stepwise treatment very quickly. We don't want to spend much time on cholinergic urticaria. Antihistamine, very good. Sunscreen, maybe. If antihistamines don't work, omalizumab has been shown to be effective. If omalizumab doesn't work, then you go on for like some more aggressive treatments, like anticholinergic, like scopolamine, for example. Danazol also can work for these patients that do not respond to anything else. But first line antihistamine, second line I like to give an omalizumab. Okay, next. What's going on here? What diagnosis? Tell me the spot diagnosis and tell me the cause as well. All from this image. So sarcoidosis, how would sarcoidosis cause? Okay, we see the keloid, yes, but I'm talking about the area that is below the keloid. So again, let's not focus on the earlobe as much as we focus on the linear color below the earlobe. If you can see this linear hypopigmented streak. What's the linear hypopigmented streak below the earlobe? Exactly, Hanan Salman. So ILK, what did ILK cause here? Hypopigmentation. Perfect. So now you can see the the condition, and you see the cause. So what happened here probably was that the patient had this keloid in the earlobe, and it was obviously injected with a high concentration of ILK, interlesional canalog. And as a side effect of this interlesional canalog, you can get this linear hypopigmentation in the area distal to the steroid injection. So perfect. So how would you manage this condition? Just waiting. There's nothing you can really do here other than just waiting for it to resolve, and it usually resolves. But they need to find another treatment for the keloid for this patient. Moving on. Differential diagnosis for this. Phytophotodermatitis. Okay, I like that. Lightning strike. Perfect. So, I mean, when you got like linear erythematous pigmentation, there's a lot of differential diagnosis, like especially when it's like somewhat flagellate, and I'm not going to go through all the flagellate dermatosis, but when you see it like this, like it looks like a fern. Fern is like, you know, the lines on a leaf all the way. Each is branching to a smaller one. This is basically lightning strike. Very obvious, straightforward lightning strike, and it helps when it's more localized in a part of the body. But even if it's widespread, this is obviously a lightning strike. Perfect. So how would you treat this patient? First of all, you congratulate them because they survived. And then you just tell them that it will subside with time, maybe a little bit scarring, but from the looks of it for this patient, doesn't look like it's going to really scar very much. Okay, next, this young patient complaining of this linear rash in the forehead. Um, let's see, lichen striatus. I like lichen striatus as a differential diagnosis. What else? Elven. These are the two on linear LP. That is very good, actually. Linear LP is also a very good differential diagnosis. So there's a lot of linear conditions, but given the age of this patient and given the way it's presenting, I would favor the three last differential diagnoses that you mentioned. And histology sometimes helps in differentiating, especially in lichen striatus when you see like, you know, the infiltrates around the sweat glands, and with Elvin you'd see features that look like seborrheic keratosis, and in linear LP you'd basically see features of LP. This condition in particular is a case of lichen striatus. So with lichen striatus, you know how to treat it. You give topical steroids, and you assure the patient and their families that it will subside in a few years. Next condition, again, spot diagnosis or spot differential diagnosis. Dermatomyositis, perfect, from the person who is named iPhone. Sclerodema, it's good that you mentioned sclerodema. You need to palpate it to know, but yeah, if it's like tough skin, I would not say that it's not sclerodema. It definitely could be. Um, Shoal sign that you're all selling. Phototoxic. I like phototoxic. Never forget the common entities. So yes, I agree with phototoxic. Maybe the patient applied a cream or a sunscreen and was wearing a short neck shirt, and this is area that got sun exposure. I like phototoxic as well. So you guys mentioned mucinosis, phototoxic, dermatomyositis. I would also add pellagra to the mix of differential diagnosis. I have to say it could also look like this. But this patient in particular was a case of dermatomyositis. Move on to the next case. Okay, so this patient, the history is reports episodic erythema and warmth in the face and in the chest. What would your differential diagnosis be? So episodic erythema of the face and chest and warmth. Still disease. I like still disease as a differential diagnosis. What else? Okay, so one of you, Ruth, said carcinoid, which is a good differential diagnosis for the actual diagnosis for this condition. Why did you think carcinoid? What does carcinoid cause, Ruth? Again, someone else said serotonin carcinoid. Why did you guys think of carcinoid serotonin? What is it that you see here that makes you think of carcinoid? That's what I'm looking for. Flushing, exactly. So what we see here is flushing. So when you see a patient with flushing, let's go a little bit deep into flushing as a presentation. Usually, I mean, especially with a guy, you don't often in your clinic see patients coming and complaining of flushing, but it can happen, and in ladies it could happen even more often. I mean, they're not going to come to you as a dermatologist, but every now and then you might come across a patient that complains to you about flushing. So when you see a patient with flushing, it's always important to think of the common entities. When I see a patient with flushing, first of all, I would think of three main things. I would think of rosacea. I would think of physiologic flushing that can happen when the patient is hitting menopause or when the patient has the tendency to flush, for example, when in uncomfortable situations. And I would think of drug-induced flushing. When you start thinking of when the patient, I mean, presents to you with other symptoms other than flushing, is when you start thinking of other entities. Like, for example, if the patient complains of diarrhea and shortness of breath, for example, you would think of things like carcinoid. If the patient has, like, blood pressure shooting up the roof, you're going to think of pheochromocytoma and to an extent thyroid conditions. If the patient has a high calcitonin in the blood, you're thinking of medullary thyroid carcinoma. If the patient has a lot of eosinophils in their blood and you biopsy and find a lot of mast cells, you can think of mastocytosis. So always think of these entities, but not from the first presentation. When you see a patient with flushing for the first presentation, think of the three most common causes: rosacea, drug-induced, and physiological flushing. Then you think of other entities. Move on to the next slide. So another theme here is boogers are made of this. So boogers, in Arabic is we call them bukhat or sanasin. In English, it's self-explanatory. So boogers are made of what? What substance are boogers made of? It's mucin. So we'll talk very quickly here about some of the mucinosis, different types of mucinosis. So what type of mucinosis is this? I need quick answers, just like that. See, linear papules. Sclerotic myxedema, perfect. So sclerotic myxedema or lichen myxedematosis, depending on how extensive and how sclerotic the underlying skin is. So perfect, the sclerotic myxedema and lichen myxedematosis. And this type of mucinosis, if I told you in the history that this adult developed these mucinous papules all over the head and neck, and then only with a few months, they all disappeared and never came back again. Papillomusinosis, I like papillomusinosis, but it would be more consistent with the diagnosis if the patient had it the long term and did not resolve. If you have papillomusinosis and it disappears completely, there's an entity called self-healing papillomusinosis. So always keep this in mind and keep this diagnosis in your mind, so that you don't overdiagnose some patients with the long-term mucinosis. So self-healing papillomusinosis. This patient has diabetes. Scleroderma, perfect, Ahmed Al-Jabal. Perfect. And this patient, mainly in the chest, between the breasts. Reticular erythematous mucinosis, perfect. Good, good, good. This one here, if you can see in the eyebrow area, the patient starting to lose hair, very thin plaque in the hair follicles and some papules in the forehead. Follicular mucinosis, perfect. So follicular mucinosis. When you diagnose a patient with follicular mucinosis, what entity do you have to keep in mind and rule it out? Perfect. Rule out MF. So this is a patient that has follicular MF. So And contrary to what you guys thought in the first about histology, there is really no reliable histology feature or anything you can do on histology that would reliably 100% differentiate between follicular MF and follicular mucinosis. Both of them can have a lot of mucin. Both of them can have atypical lymphocytes. Both of them can be monoclonal in genetic testing. So you need to really correlate clinically and histologically. When the patient is younger, like this patient, more localized, and when you do a histology, you see more mucin than the atypical lymphocytes, you think more towards follicular mucinosis, especially in the head and neck area. When you see it is more extensive, involving a large part of the body, on histology, you see much more atypical lymphocytes than the mucin, and uh, and you see monoclonality on your clonality testing, you think more of follicular MF, and it's very important because follicular MF is the type of mycosis fungoides that is more aggressive than the actual the regular patch plaque type. So yeah, but then again, I repeat, there's no single feature that would make you think that this is follicular MF or follicular mucinosis. You have to get all the data you can and extrapolate it, and there you can formulate the most likely scenario. And even when you make a diagnosis of follicular mucinosis, you have to follow up the patient to rule out progression or unmasking of MF. This patient has it only acral papules that are not increasing or decreasing. Exactly, acral persistent papillomusinosis. Perfect, Dr. A. Done with the boogers and mucin. We'll talk about some micro monsters. This will also be a little quick. So, what micro monster is this? By micro monster, I mean microorganisms. So don't get scared. So these are copper pennies. Where do you see the copper pennies? Chromoblastomycosis. Perfect. Both Dr. A and Ahmed Al-Jabal. What is this? This is the mariner's wheel, which is paracoccidial mycosis. Perfect, Salih and Dr. A. And iPhone as well. And this. This is not, I mean, it might look like a morula, but think of it, this is much larger. Like, you know, the morula, usually that you would see in portothecosis, it's usually very small. It would be as small, so small that it would fit inside a multinucleated giant cell. This is huge. This is really huge. Globi, for who said globi, usually globi are large histiocytes. So this is a histiocyte. If it's increasing, it's going to be a little large. But what you see here is huge. Rhinosporidiosis, I like rhinosporidiosis as a differential diagnosis. But this actually is something you would get in the southwestern USA. Usually, it presents with a lot of chest symptoms. Exactly, coccidioid mycosis. So this is coccidioid mycosis. Perfect. What about this? On the left side is the HNE. On the right is the GMS stain. Good, MK. Lobomycosis. Lobomycosis. Perfect. Which animal do you think of when you think of lobomycosis? Dolphins. Good, dolphins. What about this? Good. This organism usually causes diarrhea, bad diarrhea when you eat from a bad restaurant, KFC, for example. Okay, so forget I mentioned that. But when you eat a food from a bad place, you get diarrhea. You can get this when it migrates to the skin. What organism is this? Amoebiasis. Perfect. So if you see the amoebiasis, it looks just initially it looks like a very large histiocyte, but when you see in the center, there's this the caryosome in the middle, and the nucleus that is like an amoebic nucleus, and it's quite distinctive, and the vacuolization in the cytoplasm. This is amoebiasis. Perfect, Hassan. What about this? Intracellular organism. So what's your differential for this? So leishmaniasis, perfect. Leishmaniasis and histoplasmosis is a good differential diagnosis. In the end, culture was what would help us diagnose, but what the histology features that would lean more towards leishmaniasis, and this is if you can see the organisms are spread out mostly in the periphery of cells that has been said to be similar to like a marquee mirror, where the lights are all in the border of the mirror. And if you can see here, the organism very, very tiny in the organism, you can see the kinetoplast in front of the organism like a safety pin. So that's a very nice way of differentiating that. Um, just a hint for you that might come into board exams. What's a good stain for leishmaniasis, other than Giemsa stain, of course? Whoever answers this would get it like a top score from me. Something that you would stain Langerhans cells with. CD1A, perfect. CD1A is a very good stain for leishmaniasis, and it is actually helpful to identify the organism. Okay, moving on. So looks like a soccer ball here, and or football, actual football. Very small inside that could fit inside the cell. What is this little monster? Protothecosis, perfect. The morular formation of protothecosis. And what is this? I think this is the last one in the micromonsters. So this entity can present with nodules on the extremities, can present with the lichenoid dermatitis, can present with the depigmentation in some parts of the body. It can cause blindness in some patients. And histologically, it's usually manifested as a large ball of, not leprosy, it presents with a large ball of male and female worms. Dr. Elston likes to call it like a big orgy of male and female worms all together mating. Not ochronosis. Ochronosis is a hyperpigmentation you get in your body when you use too much depigmenting cream. Onchocerciasis, perfect. Onchocerciasis, Onchocerca volvulus, perfect. So yes, this is a case of onchocerciasis. So when it presents as a big nodule on the skin, we call them onchocercomas. Okay, so another section, which might be the last one for today because we're running out of time. I got you a few cases from the journals of the last few months, just very quick cases that I thought they were a little bit interesting, not too rare and then not too common. So for me to share with you, we got this, a little bit depressed, a little hyperpigmented, involving the extremity. What is this? Morphea. Okay, I can use it as a differential diagnosis, good, but this is soft, not hard, a little bit depressed, a little hyperpigmented, without any firmness, without any atrophy. Or there's a little bit atrophy, I have to say. Linear nevus, also good. What else? Groove sign? No, I wouldn't agree with this one. Think of entities that are sometimes thought of as a consequence of morphea. Okay, so Hanan said Erythroderma of Pezzini and Perini, and I like that. You're on the right track. But what do you call Erythroderma of Pezzini when it's linear? When it's linear on an extremity or on the body, when it's just a linear area of Erythroderma of Pezzini. We call it Erythroderma of Mulan. Exactly. Erythroderma of Mulan. Molin, though, not Mulan, Mulan, the Disney princess. Okay. Next. This patient has inflammatory bowel disease. This is the only hint I will give you, and this is the only hint you will need. This is a straightforward clinical diagnosis. What if I told you this patient has ulcerative colitis? What type of PG is this? Very characteristic of this is a type of PG that occurs almost always in patients with inflammatory bowel disease and in colitis more than Crohn's. Pyostomatitis vegetans, perfect. Pyostomatitis vegetans. You can see here how they're like linear pustules in somewhat of a snail track, but then it becomes too extensive, like here. Very good differential from you guys. Young child, let's say just adolescent, presenting with these erythematous papules and redness and flushing of the nose that is episodic. So young patient, episodic flushing of the nose, granulosis rubenaceae, perfect, very good. And usually you would treat this either with topical, low potency topical steroids, or you would just reassure the patient and their families that this condition resolves by the time the patient becomes an adult, like in a few years. This patient, one of the last few cases we have for today, then we'll have to make a hard stop because we're running out of time. MF. Okay, so this. Okay, I have to say from now that this is not MF, but perfect for the person who said MF because when I see this patient, the first thing I have to rule out is a hypopigmented MF, and I would definitely biopsy this patient. Senior versicolor, I like it. Progressive macular hypomelanosis, I love that differential, and leprosy, they're very good. You guys are covering most of the good differential diagnosis. So you really went through all the good differential diagnoses I can think of: leprosy, MF, PMH, pityriasis alba, tinea versicolor. I like your differential diagnosis. Hypopigmented sarcoidosis, I really like that. Very good differential diagnosis. So this time I'm not going to show you a histology image. I'm going to show you a Woods lamp image. So now with the Woods lamp, what is your diagnosis? I don't know if you can see in the hypopigmented area. There are these orangey dots, fluorescent dots. When you see these, the diagnosis becomes very easy, and that is progressive macular hypomelanosis. Progressive macular tinea versicolor usually would cause like a greenish or yellowish fluorescence. Progressive macular hypomelanosis because more recently we found out that progressive macular hypomelanosis, a condition that we initially thought that we cannot treat it like idiopathic gastric hypomelanosis, turns out that this condition is really related to Propionibacterium acnes in the skin. What we're seeing is just the coproporphyrin that it produces and fluoresces, and treatment for it, because now we know the pathology, we can just treat it with benzoyl peroxide or topical clindamycin, and it tends to improve the condition. Minocycline is also a possible treatment option if the previous treatments didn't work. Okay. This condition, you usually see it on your legs, but I put this image for you to be aware that it can also be seen in places other than the legs. Elephantiasis nostralis verrucosa, perfect. So when just to remind you that this condition can happen in any part of the body that has a lot of gravity working for it. Okay, this is not a clinical diagnosis. When you see a papule or a nodule like this, you would have to come up with a biopsy. And this is the biopsy you're seeing here. And this is the type of cell. Can anyone tell me very quickly what the diagnosis here would be, since you know the type of cell here? And if I told you that this patient has Morituri syndrome? So someone said MK is xanthoma. It's not much of a xanthoma because you can see the lipid vacuoles inside the cells here. These are sebocytes rather than xanthoma cells. So sebaceous carcinoma, perfect. Sebaceous carcinoma is the diagnosis for this patient. I put it for you as a reminder that sometimes when you see it outside the head and neck, you think of things like Morituri syndrome. Okay, this patient is a known case of malignancy. I forgot which malignancy the patient has. It's either lung cancer or breast cancer, but it doesn't matter. Just remember that the patient has cancer, either lung cancer or breast cancer, but presents to you with this rash, and the patient's on remission from their cancer. So, what would your diagnosis be? So, I see a lot of people saying erythema geratum repens. One person says tinea ambientaceae. Tinea ambientaceae is usually the one that occurs in the scalp that looks like psoriasis in the scalp. Um, okay, so most of you are saying erythema geratum repens. You take a biopsy for the patient and look at the stratum corneum. Look between the busket weave and the compact stratum corneum. What do you see there? Someone said some form of tinea. So as vague as that answer is, it is more correct than erythema geratum repens. So yes, this is tinea concentricum. So okay, I put this image for you not to trick you or to like troll you, but to remind you that common things are common. We read in the books a lot about erythema geratum repens, but I personally have only seen it one time in my life, and I've seen a lot of patients with lung cancer and breast cancer. So what's more common when you have lung cancer and then have a tinea infection, or when you have lung cancer and have erythema geratum repens? It's the first. Tinea infections are common, so always think of the common entities. This patient has tinea concentricum, who someone said, how can you differentiate clinically? First of all, can you differentiate clinically? Tinea would be more scaly, as you can see here. It's very scaly. And second of all, bedside diagnostic, you scrape it, you POH it, and the diagnosis will be very easy for you there. So, 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 yeah, that's clinically. And then histologically, like I showed you, you can see the fungi very obvious in the top of the lesion. I just put this image as a reminder for you. Always think of common entities. I know we, as as residents, you have a love for the spectacular and the things that are more examinable. And when they put for you a scenario of a patient with cancer and you see this rash, you think of EGR. But always, when you wear your clinical hat and see your actual patients, think of the commoner entities. Okay. So moving on, I think this is the last one I'm going to show you today. Um, Papule on the occipital scalp, and this is the biopsy. What would your diagnosis be here? So clinically, when I see this, I would definitely say acne keloidalis nuca. I agree with you 100%, Mariam, but histology looks like something else. Histology looks like sarcoidosis. So, and you can see the granulomas, the sarcoidal granulomas, and on the right hand, the point, what I'm pointing is the asteroid body as well. So this is a case of sarcoidosis. So always remember, if you go back, don't forget this patient is of skin of color, and it's involving the head and neck. Do not ignore sarcoidosis in this patient. So sarcoidosis for this patient. So perfect. I hope you like these cases. Oh, we actually have more, but I think we'll have to make a hard stop right now, and we'll finish it next time with the next Kodachrome. Um, we will be moving on to Dr. Rawda, who will answer the quiz, which not many people saw it the first time, but then we reminded you about it. So please, for the next quiz, answer it. It's very nice. She chose very nice questions for you, and she will go through the answers right now in a couple of minutes or in a couple of seconds.
Well, hi, Dr. Amin. Thank you so much for the lecture. Could you just host me so I can share my screen? That will be much better.
Yeah, okay. Just give me a second. I'll do it right now.
Yeah. Well, thank you so much for the very nice variety of the clinical cases. I will just review the quizzes. Well, thank you so much for the people who did answer the quizzes, and I motivate all of you next time to answer the quiz. Okay, it's for your own benefit and motivation to move forward for your studying. Sure. I'm really sorry for this, just a bit of technical issue. Can everybody see the screen? Guess I cannot see the chat. Okay, chat at the side. Okay, so we'll start the quiz now. Just 1 second. So first of all, congratulations for the highest mark. Dr. Munira Al-Hamadi, well done, excellent job. And let's review the quiz now. Okay, so the first question is, according to the present World Health Organization guideline for an adult with post-bacillary leprosy, which of the following is the most appropriate initial treatment regimen? Oops. Rifampicin and dapsone for 6 months, or is it for 12 months? Rifampicin, dapsone, and clofazimine for 6 months, or 12 months, or for 18 months? Well done. Yeah, that's C. Rifampicin, dapsone, and clofazimine for 6 months. So the 2018 guideline for the treatment and prevention, uniform multi-drug therapy was introduced, leading to the standard regime for post-bacillary and multibacillary leprosy, with a difference only between the duration of the treatment. So the previous one was for 6 months and was only for rifampicin and dapsone, but the recent guideline is for 6 months. For 6 months with the uniform multi-drug. For multibacillary, don't forget that it is for 12 months. So for 12 months is the multibacillary leprosy. Okay, moving on to the second question. Which of the following is not a potential contributing factor to a recent trend in an increase in melanoma incidence? You can just type in the chat box so I can see your answer. Yes, most of you get it right. That's an increase in vitamin D consumption. As you know, the exposure of ultraviolet radiation is a predominant risk factor for melanoma, although there is a great awareness of vitamin D, but there is no evidence that vitamin D can increase the risk of melanoma incidence. Skin cancer screening on the past few decades, increasing the likelihood of detecting of unrecognized melanoma. Okay, and it has been suggested that a previous underdiagnosis resulting from improving the histological diagnostic criteria, allowing melanoma to be recognized more accurately at an earlier stage, and that contribute to increase the risk of melanoma incidence. Okay, so move on to the third question. That's more of a clinical question. So a 42-year-old male was recently diagnosed with a plaque psoriasis affecting 15% of his body surface area. He's a corporate consultant and frequently travels internationally for work. You plan to start him on ustekinumab because of his convenient dosing schedule. You conduct all screening investigation, and he has a positive quantiferon test, but a negative chest X-ray. So what will you do for this patient? A patient needs a multi-drug therapy for his tuberculosis at least 12 months prior to starting any systemic drug. Patient needs a complete of 9 months isoniazid prophylaxis, but can be started on systemic drug 1 to 2 months of a prophylaxis. Since chest X-ray is negative, patient can be started on systemic psoriasis drug without any need for a prophylaxis. Patient is not a good candidate for systemic treatment and should be managed with topical only. Patient should be switched to another systemic agent. What do you think? Yes, exactly. So the answer is B. This we describe in this case is the latent tuberculosis that have a positive quantiferon test, but they have a negative chest X-ray. And according to the CDC guideline, the patient have to complete the 9 months of isoniazid, and still you can start the patient on the systemic biological treatment 1 to 2 months after a prophylactic treatment. Well done to the people who's answering. A 62 years old man recently underwent a treatment for rituximab prior to his allogeneic hematopoietic stem cell transplantation. Several weeks later, he presented to the hospital with a multiple deep subcutaneous nodule. some with a central scar. What angioinvasive fungal infection should be considered in this patient? Aspergillosis, ulcerosis, mucorsis, siderospirosis, all of the above. What do you think? More people to answer? Well done. Yes, it's E, all of the above. So all angioinvasive fungal infection can present especially with patients with immunocompromise. Such patients who underwent allographic hematopoietic stem cell transplantation, and for more specific, we need a further workup of the patient. As we know, we need to have a skin biopsy. Okay. Moving to the fifth question, there are many shared risk factors for angioinvasive fungal infection, including immunosuppressive, malignancy transplantation, trauma, and chronic disease, such as HIV and AIDS. Which risk factor is more specific for development of mucormycosis? Autoimmune disease, corticosteroid use, diabetes mellitus, hypercholesterolism, or iron overload? What do you think? In between C and E. Okay, well, the people who said E is correct. Exactly. Just focus on the question is the most common. Okay, so it's a well-known violence factor for a mucorales are the ability to sequester iron from the host organism. An iron overload syndrome, including patients requiring a frequent red blood cell transfusion in the setting of a transplant or hematopoietic disorder or medication that chelate iron such as defuroxime, representing a potential risk factor for the infection. Mucormycosis frequently implicated pathogen in patients with underlying hematological malignancy, hematopoietic stem cell transplantation, malnutrition, neutropenia, or treatment with immunosuppressive medication, or chemotherapeutic tumor necrosis factor and corticosteroid. Additional risk factor can include the diabetes and the autoimmune disease, but the most common is the iron overload. Okay, question 6. The hair shaft abnormality seen above, most commonly in which syndrome? You think? Nexus, Luzanogen, Menkes disease, Netherton, trichothione dystrophy. Well done. D, the correct answer. What do you think? What do we call this? What do we call this hair abnormality? Exactly, trichexis invaginata. That's correct. Trichexis invaginata is interception of the distal shaft into the proximal hair shaft, giving the bumbo hair appearance, seen more commonly in Netherton syndrome. Anyone know what is the gene mutation? Gene mutation of Netherton syndrome. SPINK5, exactly. That's correct. It's a trait of 3 important clinical symptoms, clinical signs. Anyone know? We discuss? Well, I put the picture as well to help you. Exactly. Yes. Exactly. The first one is the congenital ichthyosis, either ichthyosis linearis circumflexa or congenital ichthyosiform erythroderma. The brittle hair that we mentioned, trichexis invaginata, yes, that's correct. And the most common, it's the most common in the eyebrow. And atopy, don't forget that. Okay, so the 3 triad of Netherton syndrome. Okay, question 7. Which organism is most commonly associated with portomycosis? Staph, strep, Pseudomonas, Klebsiella, Proteus. Yes, well done. It's A, Staph aureus. No, actually, Netherton is more common with Trichexis invaginata for the previous question, Dr. Ruth. Okay, so Staph aureus is the correct answer. Portomycosis is the granulomatous bacterial infection, most commonly caused by Staph aureus. And can anybody tell me what is the disease that caused by Portonella? So portomycosis. Okay, let's keep the question. Other causative organisms include Strep, Proteus, E. coli, Pseudomonas. Lesion typically as a nodule, ulcer, and draining sinuses on the extremity. This question. The treatment of the choice for bacillary angiomatosis, which of the following? Penicillin, gentamicin, clarithromycin, vancomycin, erythromycin. Do you think? Well done, erythromycin. Yes, that is the correct answer. And bacillary angiomatosis caused by Portonella. Could you tell me what disease is associated with the Portonella? Cat scratch disease, yes, that's correct. That's absolutely correct. Clinically, the condition associated with widespread biogenic granuloma-like lesion, with or without involvement of lymphoreticular symptoms. The treatment of the choice, of course, is erythromycin 250 to 500 milligram QID for 4 weeks. Okay. There we go. Alopecia areata is characterized by which of the following? Increased lesional CD8 to CD4 lymphocyte ratio, early loss of sebaceous gland, and excess of androgenic hormone, presence of interbulbar Langerhans cell. Let's see the answer. More to come. More people to participate. Yes. Well, yes, most of you get it right. It's the presence of interbulbar Langerhans cell. Actually, most of the people, they get it wrong on the quiz. And as we know, there is a predominance of mineralized early anagen-intelligent hair structure, normal or atrophic sebaceous gland. Also, the presence of inflammatory cell, mostly consisting of lymphocyte attacking the hair ball, appear as a swarm of bees. Always remember the alopecia areata and the swarm of bees. And then infiltrate mainly CD4 cell, the helper cell, lymphocyte, and unlike the normal hair follicle, and usually they be around the interbulbal with the Langerhans cell. Okay, as we see here, the swarm of bees around the hair follicle. Okay, question 10. Red-Steinberg cell is a classic nodular sclerosing Hodgkin disease, stain positive for which of the following? LU22, leukocyte common antigen is 100 or K1. Okay, yes, guess everybody is agreed on this. It's Chi1, absolutely right. The atypical, the typical one is stained with Chi1 antigen. The atypical one is stained with the leukocyte antigen. It's a little bit of, you have to focus on the question exactly. Okay, that is a nice spot diagnosis. A claw-catching ball describe the histological finding of which of the following? Lichen planopilaris, Lichen netidus, Lichen striatus, Lichen aureus, Lichen planus. Yes, yes, more people to participate. Yes, absolutely right. It's Lichen netidus. So as you see within the Lichen netidus, so Lichen netidus here, the discrete papule of the Lichen netidus demonstrate the lymphocyte and the histiocyte, and they extend all the way to the epidermis, which make the epidermis flattened, while the retiridges, they extend downward, creating this seeming like it's catching the ball appearance. Okay, so some of the diagnosis will be really helpful if you look at the low power. It may guide you toward the diagnosis, and then you have to look at after the high power, then you will see the infiltrate more. So just let's see a couple of appearance in the derm path that resemble a certain clinical diagnosis, and anyone can just type in the chat box, what is the diagnosis? Box shape, squared of appearance. What do you think? Absolutely right, morphia. That is correct. That is correct. Morphia, see, it's like a compact box shape like. Okay. Chicken wire or fishnet. And that's mainly, as I just kind of telling you a little bit of the diagnosis, that is an intercellular deposition of IgG and C3 between the epidermal cell. Yes, absolutely right. It's Pampius vulgaris. Yes. Fried egg appearance, which cell? Mast cell, exactly. And where can we see the most of kind of aggregated mast cell? Any disease in particular? Mastocytosis, absolutely right. Well done, Dr. Ahmed. Okay, jigsaw puzzle appearance. Yes, absolutely right. Very interactive session. Cylindroma, and cylindroma is a benign tumor of the hair follicle. It have these kind of irregular shaped island of basaloid cell. These basaloid cell, we see it as well in the BCC, but these kind of different, like aggregated all on the top of epidermis. But these basaloid cell with a jigsaw kind of like this appearance is cylindroma. Okay, kind of, I think before the last one. Sawtooth appearance. Sawtooth appearance, yes, absolutely right, lichen planus. It's like the irregular hyperplasia of Malpighian layer, spinous layer, in a triangular kind of pattern would just give kind of the look of the sawtooth appearance, the lichen planus. Okay, septate tomato appearance. What do you think? Very classical. Yes, absolutely right. All of you are right. Molluscum contagiosum. Both these, what you see, the epidermal invagination and the numerous eosinophilic viral inclusion bodies all the way going up, and that's very classical for Molluscum contagiosum. Well done all. And that help you most of it for the histological part. Okay, let's go to question 12. Supratrocular nerve branches. What do you think? Ophthalmic branch of trigeminal V1, maxillary branch of trigeminal V2, mandibular branch of trigeminal V3, cervical plexus. Well, you know your anatomy very well. Okay, that's correct. Ophthalmic branch of trigeminal. So that's the trigeminal nerve, all the way giving lots of branches. One of the main branches is the ophthalmic nerve and giving the supratrocular nerve as a first branch. Okay. Which of the earliest gestational age is the epidermal development most likely to complete? Week 12, 15, 20, 22, 28. Okay. Yes, most of you get it right. It's D, week 22. Okay, because as we know that week 12 is the starting of the formation of dermo-epidermal junction. Week 15, the melanin production. Week 20, the hair follicle keratinization. And week 22 is the epidermal development. Okay. 14. Granulation tissue is initially composed of which of the following? Initially composed of which of the following? Collagen 1, 2, 3, 4, or 6? Yes, variation with the answer a little bit. Yeah, just concentrate on the question initially, okay? Because as we know that granulation tissue change later on. Okay, I guess most of you get it right. It's collagen 3. As we know that collagen 1 is located mainly in the dermis, in the bone, ligament, and tendon. Collagen 2 in the cartilage and vitreous humor. Collagen 3 in the fetal skin and the blood vessel. And also the granulation tissue, the first stage, it's collagen 3. Then later on, the granulation tissue changed to collagen 1. Okay, collagen 4 in the basement membrane and collagen 6 in aorta and the placenta. Okay, which of the following is positive or elevated in patient with Wegener granulomatosis? That's an easy one. What do you think? C-ANCA, B-ANCA, IgE, cryoglobulin, or anti-C1q antibody? Yes, well done. It's C-ANCA. That is correct. C-ANCA with Wegener. Don't forget that B-ANCA and IgE with Chart-Strauss, cryoglobulin with cryoglobulinemia, anti-C1q in arterial vasculitis. And thank you. Thank you all for attending the second meeting session. Hope you all get the benefit, and hopefully for the next quiz, we will all get motivated to answer, and when we will congratulate the first winning, the first highest score. Okay, see you in 2 weeks' time for the next meeting with Dr. Amin, inshallah. Thank you so much.